For starting late. We had to wait for the conclusion of a virtual sitting of the legislature. Today they were voting on the budgets, so the Premier and the MEC could not log off without voting, but we are now ready to start. The legislature is still proceeding, but the Premier and the MEC are now here with us. So we're going to start. This is our regular media briefing update. So we'll do as we always. We will have research and insights from Dr. America Wonga and Professor Bruce Melado. And then we will take you through some of our programs, including the vaccination rollout program, and the Premier and the MEC will talk about some of the issues that we need to deal with, especially as we respond to as we try to survive the third wave. Okay, without any further waste of time, I don't see the presentation here. Are we ready? Then I'll call upon Dr. Kawonga to come and start.
Thank you. Thank you very much. Good afternoon, Premier. Good afternoon, everybody. Welcome to this media briefing. As usual, I will start with presenting a few slides on the status of the pandemic in Gauteng. And Prof. Melado will come and present on the predictions and where we are in relation to the predictions, and then I'll come back at the end to just wrap up. So, as I'm sure we're all aware, this has been a tough week for Gauteng. We've seen the highest cases recorded since the pandemic started. We've seen the highest percentage test positivity since the pandemic started. So we're not in a very good situation in terms of COVID-19 pandemic. As the graph shows here, this graph really is showing the 7-day rolling average of daily new infections of COVID-19. The orange line is Gauteng and the blue line is South Africa. If you can look very carefully at the first and second wave, there was quite a big gap between the orange line and the blue line. So the gap between the orange line and the blue line was the other provinces in the country. The orange line represents what was happening in Gauteng. But as you can see, when the third wave, since the third wave started, the gap between the orange line and the blue line is very small. So this is really just bringing home the fact that Gauteng is driving the COVID-19 pandemic in South Africa in the third wave. So the contribution of all the other provinces to the current South African third wave is minimal. And this was borne by the fact that in the last few weeks we've been seeing between 60 and 62% of all new cases in South Africa have been reported in Gauteng province. On the 23rd of June, as I mentioned earlier, we had the highest recorded cases since we started the pandemic of over 10,000 cases in one day, and this was 62% of all cases in South Africa. On the 23rd of June, on that day, we also had the highest number of tests conducted in our province since we started. And this was over 30,000 tests conducted that day. So part of this is attributed to the fact that we did more testing, but it's also just an indication that despite the high testing, we're still picking up a high number of cases. So I'm just showing this graph to just put the first, second, and third wave into context in relation to the other provinces. And I'm focusing on the coastal provinces because that gives us a good way of comparing the second and third wave between the coastal provinces and Gauteng. So those various lines indicate the different provinces. The black line is the Western Cape, the blue one is KZN, and Gauteng is the red line. The yellow one is the Eastern Cape. And what this graph is showing is what we refer to as the incidence risk. This is the number of new cases per 100,000 population. So it's a very good way of comparing the caseload of COVID-19 across areas that have different population size. So as you all know, Gauteng contributes 25-26% of South Africa's population. It's very different from the Western Cape, which has almost half the population of Gauteng. So it's just a way of indicating what was the caseload during the second wave versus what is the caseload now during the third wave. So if you focus on the first wave, I think the caseloads were fairly similar. So the Eastern Cape and Gauteng were slightly higher than the Western Cape and KZN, but not that marked differences. When it came to the second wave, as we all know, Western Cape, Eastern Cape, KZN were 2-3 weeks ahead of us. They started their third waves before we did. And they peaked at case incidences of 45 and 47 per 100,000 population in the second wave. But Gauteng, as you all know, we sort of got off a little bit lightly. And that's probably because the lockdown level, alert level 3, was implemented just in time to stop the trajectory of the pandemic and allowing us to peak with it 2 weeks after the measures had been implemented. So we peaked at 34 cases per 100,000 population. So that just shows that the second wave was dominated by the coastal provinces. But those roles are now reversed, as you can see in the last line. Gauteng's case incidence has, on the 21st of June, we had reached the same level of case incidence as KZN and Western Cape had at the peak of their pandemic. So I think what it just shows is the other provinces, as I mentioned, they're currently lagging behind. We're not sure what's going to happen there, but we are the province that's dominating the pandemic at this point in time. I'm just going to show 2 slides to show us the extent of the pandemic. I don't want to go into too much detail today, but because I think we're all aware of the numbers. So this slide here is the 7-day rolling average of COVID-19, daily COVID-19 cases in Gauteng. As you can see, the first and second wave were very similar. We peaked at just over 5,000 cases, a 7-day rolling average in both the first and second wave. We're now in the third wave, and as of 23rd of June, we were sitting at just over 8,000 7-day rolling average. So it's just showing, the extent to which this pandemic is bigger. This wave is bigger than the first and second wave. So if you look at the 2 arrows that I've put there on the right wave for the third wave, you can see alert level 2 was implemented on 30th of May. That was just over 3 weeks ago. Clearly that alert level was not sufficient to stem the tide. Alert level 3 was implemented, the president announced it on 15th of June, but it started on 16th of June. So we're now on day 8, at least by the time this data was presented. It might be too soon to see what the impacts are, but so far there hasn't been any impact clearly because the number of cases has increased. And as I said yesterday, we had 10,000 cases per day. So just the other slide I want to demonstrate about the extent of the pandemic is the percentage test positivity. So this is what percentage of all tests that were conducted came back with a positive result. And as you can see from this curve, and this curve is really just showing starting from the second wave, in the third wave, as of 23rd of June, the 7-day rolling average of percentage test positivity was sitting at 24.1%, which exceeds the peak percentage test positivity that we reported in the second wave. And the daily percentage test positivity yesterday was 37%, as I mentioned. So a test positivity of 37% is extremely high. And what it means is there's a very high and increasing risk of transmission in the community. Because it means that there are many people in the community who we have not even picked up. There are many more who are positive who have not been picked up by testing. And the thing that's worrying us even more about the percentage test positivity is that despite the fact that we've ramped up our testing And as I mentioned yesterday, we tested 30,000 in one day. We're still having a very high percentage test positivity. So this means our testing is not keeping up with the rate of transmission in the community. So that's the big concern that we have regarding that. And you can see the red line there, 5% is what the WHO recommends. We should be below 5% for us to say the pandemic is under control. So the last thing I want to say about this slide is really to just show the table on the right-hand side, which is indicating that across the country, all provinces have exceeded 5%, exceeded 10%. There's some that are still under 20%, but several of our provinces are above 20%. And Gauteng is leading, as I mentioned, as of yesterday, with 37% test positivity. So this is, again, a very high and increasing level of transmission in the community. So just to summarize the indicators that we have been tracking, these are indicators that tell us what is the risk of infection in the community, or the level of transmission in the community. So all our indicators for more than 5 weeks now have been showing us that we're at a very high level of community transmission. And it's as indicated on the table, we look at the number of new cases, number of new hospitalizations, number of deaths, and percentage test positivity. So in all those 4 indicators, as you can see, we've been seeing an increase week on week in the level of each of those indicators. So as I mentioned, indicating a high level of community transmission in the community. So at this point, I'm going to hand over to Prof. Malado. He's going to do his presentation on the predictions and where we are relative to the predictions, and then I'll come back and wrap up at the end. Thank you.
All right, so thanks a lot for having me, Premier, HOD, MEC. I'll be talking about where we are in the pandemic following Dr. Kawanga's presentation, and what the predictions are, what the data is trying to tell us. So as you know, as already indicated by Dr. Kawanga, we are now solidly, of course, in a third wave. You see there the daily increase in the number of positive cases, which are strongly coupled with the positivity rate that Dr. Kawanga indicated. One issue that we're really very worried about is the spike we saw yesterday with almost 11,000 cases. At this stage, as you will see later, we would have expected numbers to be smaller. So we're clearly very concerned. If the spike continues at the same level today and tomorrow, we certainly have to raise awareness and sound the alarm that we may be going towards a second spike. Hopefully that doesn't happen. Now, where we are is in order to assess where we are, it's very important to look at the acceleration of the numbers. How many more cases do we have with respect to the previous week? That's very, very important. So as you know, the spike that occurred 2 weeks ago experienced about a 74% increase with respect to the previous week. That dropped to 58% the week after, and now we are at the level of 44%. Now, it's good that the acceleration drops, that the rate of growth drops, but it's not dropping fast enough. And as a result, as you will see later in a minute, due to a lot of mobility and also lack of adherence to social distancing, we are not dropping fast enough so as to release pressure on the hospital system, which right now is very, very high. So one of the reasons why we are where we are today is the fact that our mobility is among the highest after the advent of the pandemic, certainly significantly higher compared to the peak or around the peak of the second wave. Now, if you couple that with relaxed adherence or diminished adherence to social distancing, you basically have a situation where the virus is spreading pretty much everywhere, and we will now look at the situation at the level of districts and sub-districts to verify what's going on the ground. These results are from the Google reports. We also look at an independent report from with Facebook data. You see the different graphs of the different sub-districts, Johannesburg, City of Tshwane, Ekurhuleni, and Sedibeng. And if you look at the lower graphs, you can see there's the level of mobility at the level of the district, which is actually very close to before the advent of the second wave, and certainly significantly higher with respect to the second wave. So that clearly seems to indicate that we don't really have, we have two sets of mobility reports that are consistent, indicating to very high levels of mobility within the province between districts and sub-districts. All right, so let's look at risk indexes to know where we are as a province and the different districts and sub-districts to try to understand the extent of the problem that we're facing. So if you look at the interactive map of the risk in the country, the entire northern part already is technically in a third wave, all the way from the Northern Cape to recently now Limpopo and in Mpumalanga. You can see that by the color code. So it basically means that every single province that surrounds, or that has a border with Gauteng is in high risk together with Gauteng. Now, we look now deeper into what's going on in the province. You look at the recent risk indexes. You can see the clear acceleration of all the districts in the province, Johannesburg, Ekurhuleni, Sedibeng, Tshwane, and the West Rand, but also in addition to the fact that, as we've been noting already for a couple of months, Sedibeng is high. Now the acceleration has picked up in the West Rand, where Ekurhuleni, Johannesburg, and Tshwane also have acquired quite some acceleration. So every single district is engulfed. So the virus is pretty much everywhere in the province. We can go deeper at the level of sub-districts here. You have the sub-districts of two of the districts, and you can clearly see that all of the sub-districts we are looking at here in the graph are solidly in the high-risk area, the high-risk region, whether it is Ekurhuleni or it is Sedibeng. And we can look at the city of Johannesburg, Tshwane. You can see that every single district, there's some differences between districts as we expected, because some districts during the second peak have had more numbers, so clearly you will have less now. But all in all, all the districts, all the sub-districts are now in high risk. So this indicates that because we move a lot, and we are not adhering to social distancing as we should, the virus is pretty much everywhere in the province. Now, the indicator powered by artificial intelligence is very important because we know we're on the third wave, but we need to understand when the peak is going to take place. And these early detection algorithms are very important to tell us ahead of time where we are. Now, unfortunately, the risk is very high, as you've already indicated. As I've already indicated, the artificial intelligence index also shows something very similar, but it's not dropping. So the moment we see the risk drop, we will basically start feeling the fact that we are above the peak. And that's extremely important for planning and whatnot. So far, unfortunately, we don't have indicators that point at the fact that we have reached the peak. We haven't reached the peak yet. All right, so let's look at predictions. These are very important in terms of planning and to assess where we are. And I want to reiterate here that the models we show are about the worst-case scenario. We always have advocated as a committee that we don't want to give to the province a wide range of outcomes or possibilities. We want to give you what is the extent of the worst-case scenario. That's what we have always been advising on, and to basically, with that, perform a gap analysis to ascertain where the province is ready for the worst-case scenario or not. So what you see here, these are four graphs that give you the data in terms of the cumulative cases, the cumulative recoveries, and in green at the bottom, I'm going to zoom in later, you can see the number of active cases and mortality. So overall, unfortunately, the worst case scenario has materialized in that the modeling of the worst case scenario describes relatively well the data. Now, we have already indicated that while the worst case scenario for the third wave is expected to be less than the worst case scenario of the second wave, that never meant or was never implied that the third wave was going to be better than the second. We always said that we have to be prepared for the worst case scenario, and all the stakeholders, public and private, needed to be ready for that eventuality. Unfortunately, we are in the middle of that worst case scenario. So let's zoom in into the green distribution there and compare the data with those models. Now, models are not there to be wrong or right. Models are there to help us understand the data and what dynamics underlie the data. So what we see up until 2 days ago, the data was actually following fairly reasonably well the green curve. That was the central value of the worst case scenario. We also graphed the 68% confidence interval, so basically the probability that the data lies within the central value within a confidence interval of 68%. And what we see that the numbers of yesterday constitute a possible deviation from the worst case scenario. And this is very, very, very worrying because up until 2 days ago, all the numbers appear to be following a trajectory. So we could say, well, the peak will happen, say, the first week of July. But what we're seeing now is that as of yesterday, we have a significant jump that now is taking those numbers to be significantly above the worst case scenario. So that is helping us understand whether the situation is under control or not. So as I said in the very beginning, if today and tomorrow the numbers are at the same level as yesterday, we certainly have to consider the possibility that we may be encountering a second spike, similar, maybe less, but yes, similar to the one we had 2 weeks ago, and that, of course, will certainly trigger the alarm in that we may need tighter and harsher measures to be implemented to curb it. Thank you very much, and I'll give the floor back to Dr. Kawonga.
Okay, so yeah, you've heard the situation where we are. In the last few weeks, actually maybe the last week or so, there have been a number of words used to describe the situation in our province: alarming, concerning, out of control, disaster. As a public health specialist, I never use those words, but it doesn't mean I'm not concerned. I am. It's just our training forces us to take the emotion out of the situation. But the situation is actually serious, as you've seen from Prof. Malado's presentation. So in summary, what we're saying is we have a pandemic trajectory that has continued to increase. And as Prof showed, it's on track towards the worst case scenario. Its modeling is very consistent with the data to show us that. And it's also quite clear, as I mentioned earlier, that alert level 1 measures did not work. It wasn't sufficient. We moved into alert level 3. We're now 8 days in. We haven't seen any impacts yet, but however, usually we expect about 2 weeks before we start to see the effect or visible effects of alert level, such as alert level 3. However, yesterday's 10,000 cases and test positivity of 37% are very worrying. I'm using the word worrying here. And therefore, hence Prof. Malado's, what he said just now about the fact that we might need tighter restrictions, and that might be what's needed right now. However, what I want to say is the worst case scenario is not necessarily inevitable. We need tighter restrictions, and that might require government-imposed non-pharmaceutical interventions. In other words, the lockdown measures that the National Coronavirus Command Council often makes a decision about. And we need to balance the health with the economic considerations. Livelihoods are always affected whenever we have harsh lockdown measures, such as lockdown level 5, even lockdown level 4. And so the recommendations we've been making to the Provincial Coronavirus Command Council and the Premier is that level 5 is way too stringent, and it will have a disastrous effect on the economy and people's livelihoods. And also it's quite late in the pandemic trajectory to expect to see a big impact. And so one of the things we've been proposing is perhaps a hybrid of existing level 3 measures together with some level 4 measures in one, if possible. But as we know, often the decision for lockdown level measures or imposing more stringent measures lies with the national level of government. However, we in Gauteng are not powerless. So there are things we can do in our province, even at this point where we're seeing 10,000 cases a day. So there are things we can do to slow down the pandemic. So I'm going to just show a slide. My next slide is, I'm really speechless, or I have no words, and so I'm going to use pictures to try and depict what I'm trying to say here about what can be done in our province, not just for this wave, but also for future waves that might come about. There are things that we as a province should be able to do. And it's just really a reminder, I guess, to all of us as we go through this slide. So the picture on the right corner there is really people lying in hospital beds. That's our big concern at the moment. We're all extremely concerned about the number of people in hospital. The number of people who are in hospital beds means that the healthcare workers are stretched and they're stressed, having to care for patients who are very sick. It's not just a physical act, but it's also draining on them also emotionally because of having to care for very sick people, some of whom die. So, and it also has impacts on individuals themselves who are sick, on their families, on the health system. As I mentioned, they're taking, we're using extremely large amount of resources. Also impacts on the economy. And so one of the reasons why this is a very big thing hospitalization is important to sort out is if it's not addressed well and we're not prepared, it leads to people can die. So if people don't have access to care in the hospital, or perhaps the care is late, or because they get there when they're very sick, people die. And we've seen data to show that the number of people dying from COVID-19 in our province has been increasing the last few weeks. Not just COVID deaths, but also excess natural deaths have been increasing. So that's actually the end point of the pipeline. How do people end up in hospital? Where do these hospital patients come from? It's not like someone is walking around, so it comes from cases. We've showed you graphs that shows that the number of cases in our province is increasing at an alarming rate. So every time we see an increase in case numbers, we're definitely 2 weeks later are going to see an increase in hospital numbers. So the cases are generating the hospitalizations. So if we could reduce the cases, we could reduce the hospitalizations. Again, the cases don't fall from the sky. They come from somewhere. There's a source. And this is what Prof. Malado was talking about just now. It's all about our behaviors. Our behavior, you can see there's a picture there, people in a crowded space, no ventilation, not wearing masks. That's COVID, during the time of COVID. So when we don't avoid the 3 C's, close contact, crowded spaces, and confined spaces that are not well ventilated. And if we don't adhere to social distancing, that picture there is showing that one case can infect potentially 2.5 within a few days. Within 30 days, that translates into 400 and something cases. That's how we generate those 10,000 cases a day. It's the behaviors, high mobility. So high mobility means we're not staying at home, we're moving around. Granted, people are going to work. We can't stop people from going to work. And so now the thing is, when we move around, are we moving around in a safe way? Are we taking all the precautions to wear our masks, sanitize, etc., not crowd the public transport spaces and so on? So the behavior is upstream. You know, when you find rotten fish downstream a river, you often have to go upstream to say, what's happening? Why are these fish ending up at the bottom of the river, at the downstream? So if we want to stop the hospitalizations or reduce the hospitalizations, reduce the deaths, we have to go upstream. We have to start by saying, how do we stop the pipeline in the first place? And so in terms of responding to this situation, I'm just going to go through quickly using these pictures. So currently, as I mentioned, the hospitalizations is the big burden at the moment. And often that is what forces governments to put lockdown measures when our health care capacity is unable to cope with the demand. And often if we can anticipate that it's likely that we will not cope, that's the time to put in the measures. It's usually because of hospitalizations. If COVID-19 only caused mild infections, we will probably not even put lockdowns in place, because it's usually because of the hospitalizations. And so the response to that, and the Department of Health is going to do a presentation to see what they're doing in response. So providing quality care, preparing their healthcare system capacity, and this means beds, health workers, oxygen, etc., etc. Who is responsible? So in red, I've put the various sectors of society that are responsible for each of these measures. So right now, it's government, but it's also the private sector. It's not only public sector institutions that are inundated with patients at the moment. So preparing for a wave rests on the shoulders of both public and private institutions. So both sectors need to prepare, ideally in a collaborative way. And so that's who is responsible there. And like I said, the presentation will be done. But then there's also another thing that could be done, alcohol restrictions. So we've already got those in the lockdown alert level 3. The question that the policymakers need to now ask is that sufficient? Because, you know, we've restricted alcohol, it's not a ban. Outright ban is bad for the economy. So there has to be a balance where you are strict enough, but perhaps not too strict that you're impacting too much on the economy. So there might be a need, for example, to increase the restrictions by banning alcohol over the weekend or things like that, for example. So how do we stop or slow down this pipeline from cases to hospitalizations? So that rests with government, but it also rests with us. So governments have programs in place to do, identify the cases, make sure they go into isolation at home. If they can't isolate at home, give them a facility where they can isolate. Identify their contacts, make sure their contacts go into quarantine for the amount of time that's required. But it's also our responsibility as individuals. So if I am told to isolate for 10 days, then I must isolate for 10 days, even when I do not have symptoms. Because that's just how we break that infection cycle. Because if I don't stay for 10 days, I'm still infectious, even though I don't have symptoms. I might go to a party and not wear my mask, and I transmit the infection to other people. So that's another thing that I'm talking about when I say individual responsibility, to make sure that we isolate, we quarantine when we're told to do so. I know it sounds authoritative, but that's just how we stop pandemics. Otherwise, it just continuing with the transmission. So how do we go from behavior? What do we do to stop the behavior to cases pipeline? So I've sort of split this into two parts. There's one part which I'm sure you've heard throughout since the pandemic, adherence to non-pharmaceutical interventions, wearing masks, social distancing, avoiding the 3 Cs, all those things that are at the bottom left there, crowded spaces. So it's each of us as individuals have a responsibility and a role, and the power. So if I'm invited to a party, and I know that there'll be more than 50 people, I have the power to say no. Or if I'm invited to a party and I'm told there are only 10 people, come, it will be fine, there'll be social distancing, we're all going to wear a mask, and I get there and I see people are not wearing masks, I do not have to stay. I can leave. And I know it sounds authoritative, as I said, but that is just what we talk about when we say about individual power. But it's also about organizations, workplaces, restaurants, all of those entertainment places, etc., playing their part and ensuring that when their patrons come in, there is physical distancing between them in terms of seating of tables. Making sure people do wear masks when they're not eating, that people are sanitizing frequently and so on. So that's what we mean when we say the responsibility is spread across. And it's also all of society. So all of us calling out each other. So if I see the Premier not wearing a mask in a meeting, I should call him out and say, hey, Premier, what you're doing is not right. So that's what I mean by all of society. We do have the power, some power, not total, but some, to do something about it. Then the part that I've put there is enforcement of the lockdown measures and mask wearing and sanitizing in open space, public spaces, etc. That rests with government, absolutely. So government can ramp up its enforcement right now. We as individuals can ramp up our adherence to NPIs, adherence to isolation and quarantine, and so on and so forth. And obviously the government and private sector have a responsibility to ensure that the capacity is sufficient to care for people. But creating capacity is the end point of this pipeline. Where we turn off the tap rests with us, all of us. And so what I've got as a last point is you, me, we. And this is we as in me, you, government, private sector, civil society, my chief, my local councillor, all of us, we in Gauteng, have the power to make a difference. Not only now, but to make sure we continue doing all of these things here for the future wave that's going to come, but it could be flattened if we can do these things. So that's my last slide. I'm going to end here and hand over to Mr. Masebe. Thank you.
All right, thank you very much, Dr. Kaonga. We will now call Ms. Nomsa Mope to tell us about the vaccination program.
Thank you, Premier, Acting DG, MC, colleagues and members of the media. I'm going to give an update of how we have vaccinated in Gauteng since the beginning of the vaccination program. I've got to go to the slide that speaks to my presentation, and it's many, many slides. I thought that these were tuned properly. There are so many. IT, how can we move this quicker? These slides are many before I can reach the vaccination program. Oh, thank you very much, Premier. I'll continue from here. So as Gauteng, we just feel that the pace of the vaccination program is not as moving as speedily as we would like to, for various reasons that I have highlighted in the last media briefing. They are multifactorial. They are based on the individuals themselves, as well as the system, the EVDS system. But the EVDS system is continuously being improved. But we are experiencing hesitancy and reluctance from the people that we intend to vaccinate. However, we do continue to motivate, we do continue to go out on the registration campaign and educating and persuading people to come forward for vaccination. So since we started the vaccination program, a total of just above 584,000 people in Gauteng were vaccinated. And as at yesterday, those that are above 60 years and older that were vaccinated were just above 373,000. And they translate to 28% of the target population. Our target population is 1.3 million. So those that are over the age of 60 years registered on the EVDS are just above 588,000. In terms of the healthcare workers, we have managed to vaccinate as many healthcare workers as we can. Out of the target of 215,101, we're able to do 197,026. This gives us 92% of the target population. We have now increased our vaccination sites to 195. Of course, this 195 includes the 56 vaccination sites that we opened, and we dedicated them as J&J vaccination sites for educators as well as admin support and the governing body personnel. And as Gauteng, all our vaccination sites, we accept walk-ins, and I think in the last media briefing I did indicate that we do accept walk-ins of frontline workers and those that are above the age of 60, whether you are registered on the EVDS or not, or whether you are registered, you got the SMS and are still waiting. You walk to the vaccination site and we will be vaccinated. We'll assist you if you're not registered and get you vaccinated. Nationally, this is how the country has performed. As at yesterday, there were just above 2.4 million people that were vaccinated. Of that total, Gauteng vaccinated above 584,000. We are followed by KwaZulu-Natal at 544 and the Western Cape at 369. And the figures as you see on the chart there. This is how we've performed per district. Johannesburg district, of course, it is expected because it's the biggest metro. They vaccinated the most at 257,359, followed by Tshwane and Ekurhuleni. The district councils, the two district councils, Western and Sidibeng, they just did just above 26,000 vaccinations. This slide just confirms what I said at the beginning of the presentation about the healthcare workers that we vaccinated. This is the target and our performance against the target, and what is remaining is just 18,075 that still have to vaccinate. Now, for us as Gauteng, in terms of strengthening the vaccination drive, we have stepped up the vaccination rollout program. As at yesterday, we launched the mass vaccination drive for educators, staff and school governing body personnel. And as at yesterday, just above 10,000 educators and staff and governing body personnel were vaccinated. And this will increase as and when we open more sites for vaccinating educators. Our target as a province is above 125,000 that we have to vaccinate in the education department. Of course, like any other vaccination program, there are exclusion criteria. For this purpose, anyone who's contracted COVID-19 within 30 days will not be vaccinated. And we are appealing to the community to be honest and truthful about this. When you get to the vaccination site, if they ask you these questions, please don't memorize and say, no, 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 no. This is important because it's got a bearing on your health. Any person that was part of the Sisonke program, whether you are on Pfizer or the J&J Sisonke program, if you've been on that program, please don't come unless if you are coming for your second dose as part of the Pfizer program. As the first J&J that we did, it is a one jab, you can't go back again. This is what we are seeing in our sites, people wanting to come back for more. Any person who has got flu symptoms or received a flu vaccine in the past 14 days will not be vaccinated. These are questions that are asked to anyone that comes to the vaccination site as part of screening before you're vaccinated. This graph just shows how we've performed across the districts yesterday in terms of the education sector. Johannesburg, as usual, will have the highest number, above 3,700, and that CDBM will be the lowest at 824. In conclusion, I think that COVID-19 vaccine, we all know, it will provide the best chance of reducing new infection, severe illness, hospitalization, and deaths. We are urging more residents who are above the age of 60 to register for vaccination. The more people we get vaccinated for COVID-19, the more we'll get to the end of the pandemic. As government, would like to thank the general public for their patience and support during the rollout program. Remember, you still have to adhere to the non-pharmaceutical interventions. You still have to avoid the 3 C's as explained by Dr. Kaunga, even if you are vaccinated. Thank you.
Okay, thank you, Ms. Mupe. The Premier will now conclude the briefing session.
Thank you very much, Mr. Masebe. Greetings to my colleague, the MEC, and the team from the Department of Health, and the team from the Advisory Committee, representing a very elaborate and diverse team, some of whom are actually clinicians. They also are on the coal face. They're able to ensure that we don't miss any part of the pandemic. So I want to once more thank Dr. Mary Kaunga and Professor Bruce Melado for the work that you are doing on a daily basis to help us not just see the 10,000 number as it comes, but help understand the numbers are coming from where and why. Why are we getting these numbers in that area? What is happening there? So they are able to also do some comparison and help us understand the pandemic much, much better. I want to share with you the conclusions of our Executive Council, that is the Gauteng Provincial Executive Council, otherwise referred to as the Provincial Cabinet, which also met last night. I will also include in that the conclusions of the Provincial Coronavirus Command Council. But some of the issues I may not go into detail because they are subject really to discussions at a national level. So bear with me if we talk about measures and then we are not too clear, it's because there's still a discussion, and we have always insisted here that some of the issues that were still subject to a discussion with the National Command Council, we may not go into detail about them because we don't want to announce things we are still discussing. But Dr. Mary Kaunga said there are also things within our control, things that we can do at a provincial level. Earlier today, I was giving a report to the Gauteng Provincial Legislature. It was by our budget vote day as the Office of the Premier. And some of the issues that we shared with the legislature, I'm going to share them with you. That firstly, that our province, like any part of the country, went through the first surge in June, July last year, You saw those graphs presented by Dr. Mary Kaunga. That's when we went through our first surge, and then we went through our second surge. And relatively speaking, we were able to contain the impact of both the first surge and the second surge as Gauteng Province. So during the first surge, we were under tremendous pressure. Our health care services were under tremendous pressure. But here in Gauteng, we didn't run out of oxygen during the first surge. We didn't run, there was a lot of continuous repurposing of beds in the province. During the second surge, we were even much better. The second surge was quick and swift. We managed to go over the second surge pretty quickly. In both surges, before coming to this third surge, which is the third wave, in both surges we continue to have the high recovery rate, although at different points, depending at which point the infections were happening on the 7-day average, but we continue to have a high recovery rate. As I said, there were periods where when the infections on a 7-day average were really high, the recovery rate shot below 90%, and at some point, I know it was, especially during the first wave, it was hovering in the mid 80% recovery rate. Even if you were to take into account the NICD's excess death, but comparing just the case fatality rate in both during the first surge and during the second surge, the case fatality rate relative to the size of the population of the province, the case fatality rate was lower. And I'm saying relative to the size of the population, relative to the other provinces, our case fatality rate was lower. The case fatality rate, come to the third surge now, and I use the surge interchangeably with the wave. Come to this period, you can see particularly in the last week, we have reached the increase in daily infections that we have not reached during the first and the second surge or wave. Daily infection rates, and even the 7-day average, we have exceeded the 7-day average of, even at the peak of both waves, we have exceeded that. Why are we very concerned? The spike that's happening doesn't suggest that we have reached the peak. The likelihood is that these numbers, unless something is done, these numbers may just keep shooting up. Over 60%, our province has been contributing over 60% of all the new cases. And there was a time when we would go as far as like 60, there are days when we go as far as like 67%, 2/3 of the cases. When you see that graph is as steep as it is of the increases in cases, and it's not steady, we are concerned that it may take a while. And Bruce was saying, according to predictions, first week of July. Now, if you think in our terms, the first week of July is still very far. If you think normally as you calculate this, you just say, well, it's next week. But in our terms, if we have got the number of cases that are continuing to increase, at least as the spike showed, we must be very concerned, because as as Mary has said, behind these numbers, the surge, behind them is the hospitalizations. So when you see so many people infected, what really, although you know that there will be those who will recover, what the big impact of those infections is how many people are getting now into hospitals. And amongst those who get into hospitals, as we have said, would be people who are patients under investigations or persons under investigation. These are people who don't yet know their results. So one of the interventions we are doing now, all our hospitals are doing antigen tests, this rapid testing, to also clear their protocols. There are protocols with antigen tests, and I don't want to go into those protocols. There are medics here. They are healthcare people. But the reason we decided that antigen testing will help us with the clearing the PUIs so that those beds are for people who are really sick is to know what the status of people are as quickly as possible. So I got a report from the ABC yesterday, Dr. Mkheti, which indicated how many hospitals on the ground are using antigen testing. And that is good to know quickly what, as I said, there are protocols with antigen testing. To know quickly, so we have been doing that also so that we know we don't have too many people piling up in hospitals, occupying beds, waiting for the results. Those beds must be occupied by people who need medical care. So that's one of the interventions that we have been making. As I say, when I spoke 3 days ago, when we get an indication of how many beds in the private sector and in the public sector, the situation changes quite rapidly. As of today, we have 5,800 people who are hospitalized. That's both in the public and the private sector. And if you look at this number, 5 days ago, it was about 3,800. So this number is increasing pretty rapidly. What are we doing? So providing bed capacity includes making sure that you clear the people who are not, as I say, PUIs, people who could best be elsewhere, so that the beds that are there are available for people who need critical care. So they've also been further additional repurposing of beds. This we have done during the first wave and the second wave. Our hospital facilities are able to repurpose part of the hospital, create additional beds. And one of the issues that has also come to the fore, the Department of Health has been looking at this issue of elective surgery. Some of those surgeries that can be, and these are clinical decisions made. They are not made by politicians. It's the clinicians who will make the decisions about which surgeries, which elective surgeries can they afford to do them later. As part of management of hospital admissions, we have also been activating all the additional beds we have elsewhere in the system created, particularly during the period of the first wave, in the course of the first wave and the second wave. That include what's called ABT beds, alternative building technologies. And the reason, some of them, there were just no admissions. There were few people needing to be admitted. Because the first places where people were getting admitted is in the normal existing facilities. So one of the things we have, in addition to the allocation of money we gave to the Department of Health in In March, starting on the 1st of April, we gave the department 1.5 billion rands to retain over 5,000 healthcare workers who were brought in just for COVID. In addition, that was done, but we still need more staff. As these numbers are surging now, the healthcare workers are under pressure. So we have taken decisions also as the Provincial Executive Council to say to the Department of Health, as we create more spaces for beds, we need to get staff. And all our existing facilities, ABT, like we put an ABT at Krisani Baragwana of 500 beds there. So the Department of Health, working with the Solidarity Fund on some, so we have said the Department of Health, go and find the people. The provincial government is reprioritizing, go and find the people to fill these beds. And this is a function of the pandemic's momentum is at a different level than where the pandemic was in the previous two waves. And we think that these numbers, even if they start going down when we reach the peak, but the beds, the hospitals are still going to be admitting a lot more people because bed admissions lag behind infections, sometimes by a week, sometimes by 2 weeks, as the clinicians always tell us. Which means we have to be ready over a longer period to deal with the consequences of this surge now, this increase in numbers. So even if we were to reach the peak, what I'm saying to you is that the hospital admissions are going to continue to be a problem whether you have reached the peak or not. And that we have to have that in mind. That's why ensuring that every bed space in the province. And here we are working with the private sector. We are working with the team. The private sector team is led by Dr. Richard Friedland, who's the CEO of Netcare. He coordinates all the healthcare facilities. I speak with him very regularly to understand what's happening in the private sector. What are they doing? Where do they have capacity and where have they? We also tell them, in our case, we still have capacity here, we still have capacity there. And what is it that they are seeing that we are not seeing? Sometimes they give also clinical feedback. And I'm not a doctor, so they give me, Dr. Friedland gives me clinical, what they are seeing in the health. And then he tells us that's going to happen in the public sector. So the public sector is always lagging behind in hospital admissions, in the number of people in the public sector. In all the two previous waves, the hospitals start to fill up first in the private sector. And then you know that the trouble is coming. That's why earlier in the week, my message was, I can't stand in front of the people of Gauteng and say, no, don't worry, there are enough beds. Looking at these numbers, it is clear the beds are taken. The bed space is taken. And getting feedback from the clinicians, they are already under pressure. And that is why we are doing a simultaneous reopening. And we have got to get, I said earlier in the week, and I said in the legislature, we will spare no energy and no any effort. We will utilize whatever resources we have to get more personnel when we have more beds. As we create beds, to get more personnel, because to have beds and not have no personnel doesn't help. So this attitude we have adopted, that let's utilize every bed given the third wave as momentum and the scale and the fact that the seroprevalence study, in other words, how widespread or how many people in the first and second wave may have contracted COVID. We got the seroprevalence study presented by Professor Mahdi here. It was done by Dr. Mary Kaunga at Wits University with our Health Department, before the third wave, they were estimating that about 38% of the people of Gauteng had caught COVID. It was even before the end of the second wave, Dr. Kaunga. So this is how prevalent was COVID in Gauteng if you combine the first wave and half of the second wave, because it was before the end of the second wave. At that time, the estimation was 38%, because they said 19%, and they said it is better when they look at everything to double the number to deal with undercounting. So if you think of it, it means there was still about 60% of people in Gauteng province who had not contracted COVID in any of the, and they gave us the number that at that time an estimated 5.9 million people out of 15 million people. That's the zero prevalence study we got. We got it last month. So when you also want to understand what may be happening, and this is the point I was sharing, is that there were still too many people who are available. Maybe if they have not gotten the virus, they haven't built the immune system, because Gauteng was relatively saved during the second wave, unlike the coastal provinces during the second wave where they got lots of infections. So I think Dr. Mary Kaunga calls it susceptibility. So the part of understanding what we may be going through, and that's why we must say to the people of the province, the pandemic is everywhere, and please play safe. Don't think this, we went through the first wave, we went through the second wave, there are still too many people, yes, who didn't get it. And that's the real danger, actually. If someone thinks, oh, I didn't get it, others got it, it doesn't give you the thing to go out and say, no, even during the third wave, I will not get it. This is severe. And there are still many people in the province who are vulnerable. I also said there are people who have recovered, and recovery here is fairly technical. You might have gotten COVID during the first or second wave. The example with myself is safer to use yourself so that someone doesn't get offended. I got COVID during the first wave, around first week of July. There are quite a lot of people who got COVID, and this may be anecdotal because the studies, we say to our team, our advisory committee, you need to advise us on how to deal with long COVID. So there is a phenomenon called long COVID, and some call it long haul. You might have been reading about it, that there are people who are still struggling with even the impact of when they got COVID in the first wave. And I must say that our healthcare system is not so much focusing on those. We are focusing on those who are immediately infected, and then they need admission, and then they need to be put on oxygen. I don't know how many people I'm speaking on whose behalf I'm speaking, but long COVID is a very, very tough thing. And the healthcare system, one of the things the healthcare system needs to do is to really be because when it is said you have recovered, it's certain assume that you move on. You hit the road like you have always hit the road. There are a number of people who are really, really struggling because this is a new virus, it's a novel virus, but also COVID itself is a new disease, we may find that there are lots of long-term impact. So what the system now is focusing on dealing with the immediate one. But the system needs to also prepare to deal with the post-COVID issues. And I can say to you that at the moment, I think the priority, yes, is to deal with that and save lives immediately. But a lot of people who have recovered from COVID need clinical attention. And that's one of those things that we have asked the team, the advisory committee, which has got top clinicians in there, and professors. We have asked them to give us an advisory beyond dealing with these rapid increases in infections. How is this healthcare system supposed to deal with long COVID? People who are really struggling, who have persistent symptoms that come probably after every 2 other days. Fatigue, chest pain, sore throat, body pain, and sometimes I get also feedback from people who say you are not alone. Sometimes there are days you just can't wake up. And by wake up, I don't mean open your eyes, but your body is like finished. So we've got too many people in our society so COVID is something that we will have to live with much longer. We have to manage the immediate situation. So this issue of expanding the capacity, both bed capacity, oxygen capacity, human resource capacity, and the issues, the technology, health technologies, we have invested. We have got a lot of capable clinicians, but most of them at this time will tell you we are struggling, we are under extreme pressure. This brings me to the reopening of Charlotte Maxeke, which we announced today. Charlotte Maxeke has got some of the top clinicians we have in this country. In many areas it provides specialized services, but even on COVID-19, it supports district hospitals, and that is why we have taken a decision that we took our time. I went in detail in the legislature today to say we took our time. Why? Firstly, we were checking what legal advice says, and secondly, we were engaging with the city, but we're getting our Department of Infrastructure Development not to come later and say we were pressurized for making emergency decisions, and then you find later that if things were not done properly, it's like, yeah, the reason is because you pressurized us. But we worked with the hospital, we got the engineers to assess, and the engineers, basic structural engineers, identified that not the whole hospital has been affected by the fire. You have Block 1, Block 2, Block 3, Block 4, and Block 5 at Charlotte Maxeke. And the engineers said it's only Block 4 as a whole and on different floors that was structurally damaged, and only a part of Block 3 and a part of Block 5, but Block 1 and 2 are completely unaffected. And that these are usable because the structural engineers are doing an engineering assessment. How you get them to use them, they say to you, no, the fire did not affect these buildings. Of course, we had to spend a lot of time with our city because local government administers every building. We had to spend a lot of time, work through with the city, but we finally reached a point where we had to, and we consulted quite widely. I personally consulted quite widely. I spoke to clinicians who put a very strong case why the reopening of the hospital will actually, or leaving it to wait until it is all the issues are addressed, which is up to September. Waiting until September when every compliance is met is not an option. And the clinicians presented to us a very clear evidence that the people who were at Charlotte Maxeke are now overburdening the other hospitals. Those hospitals have their own patients. But Charlotte Maxeke also is needed. You know, if you have a player in a team, you have a player that can play and it's critical time. And you can't afford to have that player there unless they are really, really out of play. You have to weigh all that. And when we weighed all the risks of keeping the hospital open and waiting until every aspect of the building requirements are met, when we weigh that with the fact that there are parts of the building that are structurally sound and they can serve the purpose they had served before, including on COVID, but also on other pressures that the hospital has, including the academic. You know, it's a training institution. So we came to the conclusion that it is better to take a decision on the side of opening parts of the hospitals that are structurally sound. And yesterday we met with several, I met with the Human Rights Commission, together with the MEC for Health. I met with the Gift of the Givers. As you know, they have really on their own been supporting the healthcare system. I met with Section 27, which is an NGO in the health sector. I met with the University of the Witwatersrand, but also consulted widely. We also had received legal advice, and legal advice is basically about you have to work on the basis of everything that the city's regulations and bylaws are saying, and if you don't do that, the city might you might even end breaking a city bylaw. I don't want to break any bylaw deliberately, but we are working with the city right now. Our infrastructure department is working with both the city and Solidarity, including sourcing out some of the doors that need to be changed are fire doors. So the old fire doors need to be replaced with the new fire doors to meet new standards. When we looked at everything and when we listened to the case being made and when we see what is happening, the conclusion we came to is that those parts of the hospital that are structurally, the engineers have said structurally they are okay, which is, so firstly, oncology department is completely redone, and it is the Department of Infrastructure Development has handed it over to the hospital today. The city is busy with the certification. So it's not just oncology that we say must reopen. There's block 1 and 2. I was saying to you earlier on that block 1 and 2 are completely unaffected by fire. And they are going to be hosting critical services. The hospital met with us yesterday and said, this is how because they've been making a case themselves, that we need the parts of the hospitals that are not structurally compromised. So they presented a plan to us yesterday. We gave them a go-ahead. So they are busy today with preparation for the resumption of critical services, oncology, block 1, block 2. Some of the critical services would include COVID. The others would include neonatal units, and there are many others that they are saying. Those are the most, according to the pressure they feel and the critical nature of that, they want those back in action. So that's block 1 and block 2 plus oncology. So this is part of our response in dealing with. So bringing back Charlotte will not solve the problem all over, but it will relieve. So there will be some, they said to us, give us some time, we will tell you how many COVID space we will have, but we will have at least. And there's some of the top professors we have in this continent are based at Charlotte, even on treatment, on dealing with COVID. So the numbers, they are sorting that out. They said to us, now that we have this go-ahead, we are busy. Oncology, as you know, is for cases related to cancer. Again, there's been pressure. Some of the neonatals, the babies, were admitted in the other facilities, but they come from Charlotte. They will return them there. And it will also relieve the pressure of the other hospitals. Chris Hani itself was feeling the pressure. Chris Hani Baragwanath was feeling the pressure when Charlotte Matlake is closed. Steve Biko was feeling the pressure because it was also taking some of the work. But we have also agreed that because Charlotte Matlake is still, there are parts that will not open immediately. Some of the Charlotte Matlake staff will also be utilized in other facilities where we have additional beds. For example, the ABT at Chris Hani Baragwanath, so they are working out the details. That ABT will also have support from the Charlotte Matlake because not the whole hospital is opening. Not all the staff are going to go back there. Charlotte Matlake will also continue to support several hospitals, they said, including Helen Joseph and Betha Boa in Ekurhuleni. Charlotte Matlake is supporting that. They're dealing with 130 beds there, COVID beds. And that's how critical Charlotte Matlake is. They are not just dealing with where they are based. That hospital supports services in the different, so we had to do everything. Everything in our power to get the facility open. So this is dealing with bed capacity, additional support for staffing. The second issue is about regulations and just ensuring that we slow down mobility and movement and activity, people going up and down. So this is important. Here we are first appealing to the people of the province. You did it during the second wave. The best time that there was greater compliance in Gauteng was during the second wave. Everybody was wearing their mask. They had gotten the message. When we said COVID is here, everybody went all out to make sure. If you leave your house, you must be having your mask. If you have visitors, people coming in the home, you don't live with them, it's advisable to wear a mask. So we saw it. We are not asking people to do something they cannot achieve. We saw greater levels of adherence to COVID protocols, but also we add in that greater visibility of law enforcement. We want the law enforcement officers to do what they did, especially during the second wave. In January this year, they were everywhere. You saw them yourself. In January this year, the law in places where you don't want overcrowding, because we also have political marches, we have political gatherings, part of the reason that we really have to clamp down on just this disregard of the regulation, because when there are high infections, so you have a group of people who were marching yesterday. When the infections hit the roof, the government is to blame. People decide to defy the numbers of gatherings. But when the infections hit the roof, and who is to blame? It's the government. And some of them even say it, that we are going to go and march without complying. They say that so. And those same people, when the infection hits the roof, we still have a lot of lack of compliance in shopping malls, in restaurants, in both the townships and the suburbs. It's like COVID is not there. And it's not a class issue. And it's not a race issue. It's not a gender issue. Across class, race, and gender. You go to the northern suburbs in restaurants, the restaurants are packed, people are not wearing masks. You go to the township on a Sunday, the playgrounds, soccer playgrounds are packed, people are not wearing masks. It's like it was 2019 before we got COVID. The shops, the establishments where, so the reason, there are things we can do to enforce this. So the law enforcement, activity of law enforcement in Gauteng will increase quite dramatically over the next few days. This doesn't need approval of the National Command Council. We are not talking about new regulations. The regulations are there. The police must do roadblocks in areas where they know. The police must enforce the curfew. That's one part of the role of law enforcement. But the police themselves are impacted by COVID. That's why we were making a call that we need to move, like we have done with the teachers, we need to move quicker to the vaccination of law enforcement officers. A lot of them, as I speak, we have a lot of officers who are in isolation, or some of them are even in hospital. They wouldn't be able to, we saw it during the first wave and during the second wave, but now the vaccines are there. So you are going to see increased police visibility, and this is going to be linked to where there are hotspots. When we know that in this area, that's why when Bruce gets the numbers of the day, 10,000, that day he is able to map through artificial intelligence. The 10,000 comes from these following areas and these following wards. And we're able to check what was happening a few days ago in that area. We go back to find there were super spreader events, without exception. Some super spreader events. So we will do what government must do, what it does. I started with hospital beds, increasing capacity to treat those who are sick. I started there because government must do its part. I started with that. But there's the part also that has to do with what citizens must do. And there's the part that says the regulations are there. You don't need, on this and that, you don't need new regulations. We also want to localize the enforcement of regulations. Localize them more. Look at an area, a locality that is a real source, like everybody there is really infected. There must be slow movement. People there need to know that there is a problem in your area. You are not the only one who is infected. There are many more people. If you're going to a shop, you are going to a chemist or a pharmacy in your local area, just know those are points of potential infection because everybody in this area. So we are increasing public communication as well, increasing law enforcement. But we want increased compliance with the protocols. That one can only, if the people are not with us. There's something that's called COVID fatigue. COVID fatigue leads to death. If you say, I'm tired with wearing my mask, I'm really tired with this. So there's something that is called COVID fatigue, where people it has been difficult. It is a difficult life. But COVID fatigue just leads to more infections, and it would lead to death. So that's one area of focus. On the regulations, we don't want to go, will we be thinking of, we have had discussions with, yesterday we met with two sectors. We met with the religious sector. Apart from the people I said we met with on Charlotte Matlake, we also met with the religious sector. To discuss the church, the mosque, the temple. Are these places where regulations are not being enforced. What we can say to you is the feedback we are getting from the leaders of communities of faith is that many of them are doing their best to observe and ensure in the church they also preach the message. That's what they said to us. Many of them, they said, many of us are getting the message to people. You must vaccinate, you must wear your mask. And they said many of us are also creating social distance in the church. We like that because we want to work with them. We don't want the church to shut down the places of worship, because in difficult times like now, when family and friends are succumbing to COVID, we respect the spiritual role, the role of the religious sector. They offer counseling, and they were saying to us yesterday, whatever we do, let's do it together. They don't want to be surprised that suddenly, and we want to assure them that we are going to be working with them. And we said to them that we must work together. If we identify an establishment, a religious establishment, that is the source of infections because people don't observe the regulations. We said the law enforcement and the religious leader, the multi-faith religious team, will work together to also go to such establishments. We're also the discussion with the liquor traders. I didn't attend the meeting myself, but I sent one of my advisors who met with them. They were doing training. They are doing training all over the country. They did training here in Gauteng for liquor traders on compliance with the COVID protocols. If you have an establishment, the regulations are clear, what needs to be done. They were also being taken through that because those that don't comply create a crisis for us. That's why the idea of shutting down each one of them. So they know that if there's no compliance, the church also know if one of you does not comply, they create a sense, they create super spreader. It means that the whole sector gets affected. And I want to say that I think that kind of sectoral support and sectoral collaboration is the way to respond to a pandemic. You can't use one arm, just use the law, the police. We don't want the police to be disrupting churches. The church, if you are a pastor in the church, that must be a place of law and order. You can't encourage your people not to wear their masks and they must be over the numbers. And we were discussing with them that let's do that with the liquor traders, at least for now. The regulations are as they are. Please don't ask me what are you going to suggest to the National Command Council. Talking, engaging with the liquor traders on the issue of compliance. And the police must shut down any establishment that doesn't comply. No mercy. Instead of worrying about the whole sector, any establishment that doesn't comply, the police will shut it down. And the liquor traders agree with us that they will do everything, whatever happens with the numbers, if the numbers are reduced. The rest we will get advice from the clinicians. Are the hospitals still filling up with trauma cases? Now when that happens, especially during the weekends, it means the weekends are a problem. We will take guidance from the clinicians. Trauma cases, and they often say, as a link with alcohol. I want to conclude by saying that we are also ramping up testing and tracking and tracing, which we did extremely well during the first wave and during the second wave. The things that worked during the first wave and during the second wave will work during the third wave. Testing, ramping up testing, including antigen testing, I've spoken about that, and tracing and tracking, that's extremely important to contain the pandemic. And the last area is about ramping up vaccination, because you can't deal with this with just on one front. That's why we are mentioning all these areas. That the vaccination program has to also be ramped up. Just here in Gauteng, we want our team to be saying every day we have run out of vaccines. That's the message we've said to them. The number of people who must be vaccinated, when we receive so many vaccines, we need to make sure that the people, and we have community healthcare workers in Gauteng. We have over 9,000 community healthcare workers who work in communities. So we can't just wait for people to come or for them to get the message from the EVDS. Our community healthcare workers are now going to be going out. Of course, they can't do crowding because where the pandemic is, we must also worry about them but we have said wherever we have sites, if we have a vaccination site in the area, we must also activate communication with that local area. There are people who have not yet received the message that you can actually come and register at the vaccination site. If you have not registered, you can register on the vaccination site and you can get your vaccine on that same day. So that this vaccination is extremely important. So we are glad that we have gone to the teachers. As I say, we make this case with law enforcement is something that is being made. The law enforcement teams, and you know that they are also. I am told that it's still a discussion about how soon can we get to the 50 to 59 years olds. There's still a discussion at the structure responsible for vaccination of national and provinces. But here in Gauteng, vaccination is going to be a very important pillar of our response. So all those things, so I'm also saying to you, we will go and find space wherever we can get it, additional beds wherever we can get them. If they are in the private sector and the private sector team is facing the similar situation, we will work on that. We're not going to, but the pressure can be less if all the other things work. If there's increased adherence and increased visibility of law enforcement and containment of areas that are sources of the super spreader events. If we do all those things, we will be able to I am confident we will get over the third wave as we did with the first and the second. It is not going to be easy. It's going to have to take all of us. It will have to take all of us to do this. And of course, as the Premier, when the surge is happening like that, I know my head is on the block, and I put it there. When the surge is happening, and I got lots of our colleagues who went through the surge at different times, my colleagues who are premiers, who at different times, whether the first or second surge, said, we went through that, Premier. There was a period where it was tough in our area, and they said, if the province need any type of support, we are available to support, and that's something I would really appreciate. The surge is here. It has not slowed down. The incline is continuing. The only people who can slow it down is the people of our province, you and I, can slow down the surge. But even if the surge was to come down, we still have to prepare to deal with the impact of it long after it has passed. Some of it is about long COVID. The other is just how long people will take to recover from hospitals. So this is the report I gave to our legislature today. And I am appealing. I'm on my knees. I'm really, really on my knees. If you know someone who is not complying, who's out there just leaving home, going to the shop at the slightest provocation, if you know someone who cannot sit down at home, this is the time to phone them. Just slow down. Don't keep going in and out when you have no reason to be out there. If you know someone, say to them, if you know someone who says, no, you know, I don't put on a mask, appeal to them. Just say to them, for the sake of the people. If you see family members, like we have had Father's Day on Sunday, come together, they just think because we are family, they can go into a restaurant, take off their masks, and the restaurant is packed to capacity. 1 out of every 3 people in Gauteng are likely to be carrying the virus. So that 34% of positivity rate is a scary statistic. So if you are 3, one of you, so let's just see how we can slow down the infection, and it is in our capacity to do so. We did it. The rest of the things will be national decisions. We want to focus on what we can do in Gauteng province. And then we are monitoring closely the schools. So far, the infection rate in the schools has been low. Yes, we closed 20 schools in Gauteng, but the infection rate in the schools has been extremely low. I think it was less than their contribution of schools to infections, just around 2%. The number of people infected were just under 2,000 when education last reported. 2,000 out of this, and it was over a period, not in one day. But if the schools become an area of great concern, fortunately the schools are closing next week, end of next week. If they become an area of great concern, they will become an area of intervention. At the moment, there's no evidence. Yes, there are infections happening in schools, but they are not the driver of community infections. There was a period during the second wave where the schools became the drive. The young kids who went to Durban came back to. They became the driver of all the infections we had in December, including infecting families, and then all the younger people were in large numbers who are friends were carrying the virus. It doesn't appear to be the case at the moment. And I'm not saying there are no infections in schools. There are schools that had to close. At the moment, our advisory committee is not seeing that the schools are a real big contributor to the surge. And when the evidence comes, we are going to act on the evidence. Thank you very much.
All right, thank you, Premier. We'll now take questions. We'll start here, and then I've got a few on WhatsApp. Do I see hands here? Yeah, please bring the mic over here. Oh, there's a mic there next to you. Oh, yeah. Sure, go ahead, yeah.
It's Mangola from ENCA. I don't know.
It's not working.
1, 2. Okay. Maybe. Okay. It's Mangola from ENCA. Premier, I have 2 questions. The first one is that there's been a lot of criticism that the Gauteng government was very slow to act when it comes to the third wave. In fact, the co-chair of the COVID-19 Ministerial Advisory Committee, Professor Koleka Mlisana, was quite scathing yesterday to say that the Gauteng government failed to prepare properly for the third wave, which is why we're in a crisis that we are in. I want to get your reaction on that, Premier, those utterances that the province was not prepared enough for the third wave. And secondly, the situation on the ground is not looking too good, Premier, in terms of hospital beds. Hospital beds are running out in the province. We're hearing reports of people being transferred to other hospitals and transferred to parking lots because of the bed capacity in the province. And one would have expected that perhaps you would have then introduced harsher restrictions to try and curb the number of infections. Why do you think it's not the time now to do that? Why are you not moving to that point of actually imposing those harsher restrictions of lockdown? Why that delay?
Lockdown restrictions. Okay.
My name is Malungelo Boy from Newsroom Africa. Premier, one of the conversations that we're hearing, especially from doctors in hospitals, is that the hospital beds are full, and this is something that you too have alluded to, and you're saying that you are already repurposing some parts of hospitals so that there can be more bed space. Are you also then looking at reopening some of the field hospitals, for example, like Nesrec hospital, which at the time we really had about 1,000 bed capacity, but 500 had ventilators and all of that. What's going to happen there? Are you going to repurpose? Are you going to reopen that that facility? Two, it's on the issue of restrictions as well, Premier. I mean, it looks like the province was caught off guard again with this third wave. What has been your conversation with the president and the National Command Council? Are you saying that there should be harsher restrictions in Gauteng? Already, Dr. Kawonga was saying that they won't. Their recommendations to you was that level 5 is already, too late for us to introduce it. What are you saying to? What did you say to the president and the National Command Council? Thank you.
Okay. All right, let me read a few that I have here. One from Charlotte Kilbane, Eyewitness News. What are likely to be the increases to the restrictions in the wake of the dangerously high numbers in GP? Will the provincial government be asking for the president to do something similar to what was done in other provinces during the second wave? For instance, declaring a special emergency level for the region, for a region that is experiencing large increases. And two, what effect is the removal of Charlotte Matleke having from efforts to deal with the third wave? I thought the Premier has already spoken about this. And three, you referenced in your budget vote the challenges around recruitment. How pressing are these challenges? How many staff need to be recruited? And in what time frames in order to comfortably, supposed to be comfortably staffed? Then four, what is the uptake of vaccination? Or what does the uptake of vaccination be like among the 60 years and over? Why do you think, or if lower than expected, why do you think that is so? When will the national EVDS open for registration for the 50s? And how long do you anticipate it will take before you open vaccination for the 40s. Then there's a question. No, I think Temba Kumalo wants a sit down. He has sent a list of questions, 14 questions. I'm not going to read 14 questions here. We will answer the questions, Temba. You even provided a deadline by when they should be answered. Then we have a question from Tembi Letele from Bloomberg. Exactly what are the restrictions which the Provincial Command Council will ask the NCCC to consider? Secondly, can the province afford to wait for the next meeting of the NCC, which is scheduled for Tuesday? And is there any consideration around implementing restrictions which are within the province's legislative jurisdiction, such as the trading of liquor? Well, okay, we will answer you. Then there's a question from Sinesipo Schreiber from Record newspaper. And this is with regard to vaccination. With the vaccination of educators having kick-started this week, we've had reports that the rollout at some points was only dedicated to the education sector. And then, does this mean that the vaccination of people aged 60 and older has stopped? And then also, what about that of health workers in the phase 2 vaccination? Has that been halted? Are we now only vaccinating educators? If not, what plans are there to manage the crowds at the vaccination points? Then another question, with the researchers warning that the third wave might be more severe than previous waves and some of the daily infections higher than the first and second wave recorded recently, how soon can the plans to expand capacity of the designated coronavirus hospitals, which are nearing capacity due to continuing a rapid rise in cases, be implemented? How is the Department of Health managing expanding capacity of the designated COVID-19 hospitals and the space for those who are sick with other diseases? Then there are a few questions here from Carol Payton. These relate to Charlotte Matleke. One, it says, Premier, your administration took 5 weeks to appoint contractors to repair the hospital. Do you find that acceptable? Since if Charlotte Matleke was open, Gauteng would have 1,000 more beds. I'm sure Carol was listening when the Premier was speaking, but we will answer. Another question still from Carol. Given the burden of neonatal care and oncology that is now on the public hospitals, have you considered making contractual arrangements with the private sector to take public patients? And then another one from Carol still. What is the timeline for the reopening of the various blocks referred to? And what is the timeline for the reopening of the entire hospital? And then I think there's a question from, let me see, from Network 24. 2 questions there. What type of restrictions are we looking at to stop the spread of COVID-19? Obviously, these questions were asked before. Premier, you mentioned that those in the age of 50 to 59 will be vaccinated next week. Is that only in Gauteng or national? How many beds in Gauteng are available? And is there any oxygen shortages currently? Then, I think lastly, I have a question or a few questions from Griselda Lewis from SABC TV News. Premier, is the opening of Block 1 and 2 with immediate effect? How many bed spaces does this now provide? And then, given that Dr. Merika Wonga has said that she thinks level 5 would have been too stringent and too late, what is it that you have asked the national government for? What is it that you have asked the national government for in terms of further restrictions? Is it true that some patients of Gauteng are being taken to other provinces due to lack of beds? Yeah, these are the questions. And as I said, Temba's questions are 14, and we will respond to those. I think, yeah, those are the questions. So the Premier and the MEC will answer. And of course, Ms. Mupe, if, the ones about the vaccination program.
Thank you, Premier. I think there are 4 questions that were related to the vaccination program. The first one was about the uptake of the vaccination. I think in my presentation I did say that the target for 60 years and above for Gauteng is 1.3 million. And of that, only just about 588,000 registered on the EVDS. And of the 588,000, we vaccinated 373. This translates to about 63% of the total population that we are targeting. So the other thing was about the EVDS, if it's going to be open to allow those that are between the ages of 40 to 59. I think the Premier covered that, but safe to say that this is what we have advocated for as Gauteng, but that decision lies with the National Department of Health. The discussions are on. As and when it is finalized, we'll be informed of the decision, and we then follow what we're expected to do. A vaccination of healthcare workers, is it going to halt? No. It is not going to halt. It's continuing. It has been running parallel to phase 2 of the program. And in my presentation, I did indicate that so far we've vaccinated 92% of the healthcare workers. Our target is 215,101, and we vaccinated 92% of that. And we said it is continuing. We are encouraging healthcare workers to come. It has not stopped. They still have to come and vaccinate. How are we going to manage the crowds at the vaccination sites? Before a person goes to a vaccination site, we know that they register, they then consent, and then they are scheduled. People that go to the vaccination sites are scheduled in the main. However, as Gauteng, we had said that even if you are not, we will vaccinate you. But there are stringent non-pharmaceutical interventions that are adhered to, as the Premier indicated in his speech, that we adhere to that at all costs. We all try by all means to make sure that there is no stampede at these sites, and also people adhere. And if you don't, we call each other out. It's been difficult because some of the community members don't take kindly to us trying to make them comply. But we don't stop. We do continue. I think that those were the only 4 questions that were directed to me as the vaccination program. Thanks.
Thank you, Premier. Members of the media, good afternoon. Okay, let me first respond to the question, Kamangoba. The second question that you asked the Premier about patients having to wait in the parking lot before they get treated. I'm not too sure where that information comes from, because where we're standing, we still have a little bit of capacity. I'm going to read from a report that was prepared by a clinical doctor in public health medicine specialist, Dr. Maluleka. Where we're sitting, I'm going only to focus on the 3rd wave. We have a number of functional beds at 3,558, and then we still have an additional number of 830 beds that the institutional functional beds that have been repurposed. I think the Premier stressed that over and over again on the repurposing of beds to make sure that we respond to the 3rd wave. And by saying that, we are not saying there's no pressure. We acknowledge that there's pressure in our hospitals, but we are doing everything in our power to make sure that we are addressing that issue. And when it comes to the question by Malungelo on the NASREC having had ventilators, NASREC has never been an ICU or high care facility. It was catering for the isolation and quarantine. I think I've responded to that question. And maybe just to give an overview per district on the admissions and bed occupancy. In the public sector, where we're sitting, public sector beds occupancy, considering only positive COVID patients, we're sitting at in the baseline of 2,728, we're sitting at 64%. In a baseline of 3,558, we're sitting at 49%. But when you add the number of PUIs, people who are under investigations, the number shoot up to 103. And I think that is the reason why the Premier was saying a decision has been taken to say, let us use the antigens to make sure that we offload the number of people that are waiting to know their status, whether they are positive or negative, so that they can be admitted. When we go to Johannesburg, in particular, where I think all of us know that Johannesburg is a driver of our infection rates. The public sector bed occupancy, when only COVID positive patients are considered, we are sitting at 84%, at the baseline of 846 beds. But when we use the baseline of 962 beds, Johannesburg is sitting at 74% bed occupancy. And then when you add the public sector beds occupancy of COVID positive patients, including the PUIs, Johannesburg is sitting at 122%. And then what they have done to respond to that, additional 138 beds at the Chris Hani Baragwanath ABT are being functionalized through HR to ease the bed pressure in that cluster. And then when we come to Ekurhuleni, they are sitting at 49% with the baseline of 668. And when we are taking the baseline of 948, they are sitting at 34% bed occupancy. And I think the Premier did indicate that we are monitoring this very closely. And then when we add the PUIs on a baseline of 668 beds occupancy, they are sitting at 86%. And as you can see that our PUIs are the ones that are driving these big numbers. And then coming to Sidibeng, considering only the COVID positive at the rate of 239 baseline, they are sitting at 47% occupancy. And then when you look into the baseline of 219, they are sitting at 52%. And then when we add the COVID positive patients with the PUIs, they are sitting at 69%, and with a baseline of 239. With a baseline of 219, they are sitting at 76%. And this is what the clinicians have done. They have sent a team or deployed a team in the district to assist in the increase of cases and hospitalization. So the team has been working and we are receiving reports. And then in the West Rand, only COVID positive patients considered on a baseline of 218 occupancy, they are sitting at 116%. And at a baseline of 287, they are sitting at 66%. And then when you add the PUIs, they are sitting at 180% on a baseline of 218, and then on a baseline of 387, they are sitting at 102. So all of us, I think, understand that the West Rand is hit hard because of the Charlotte, because they fall under that cluster. But with the opening of Anglo Gold Ashanti in the West Rand, they had been decanting their patients to Anglo Gold, and then we'll see at least those numbers going down. And then in Tshwane, with the COVID positive patients on a baseline of 799, they are sitting at 44%, and then with a baseline of 1,042, they are sitting at 34%. And then we also are monitoring that to make sure that they are not overwhelmed without us being aware of it. And then when we add the PUIs to the COVID positive patients, at the baseline of 799, they are sitting at 81%. And then at the baseline of 1,042, they are sitting at 62%. So basically, those are the beds that we have made available. Thank you very much, Premier.
So if there is a hospital that has transferred patients to another province, Mangoba, I would say that we would, as things stand, we would find, if it's in the public sector, we would have found a bed for that patient, as things stand. We can take the patient as far as possible, but still in the province, either in the north, as far as possible at Anglo Gold in the West Rand, because those spaces are operationalized. We don't have, they are not full. And I'm also going to check with my private sector colleague if in the private sector they have done that. I can also tell you that even at Charlotte ABT, we would have found a space for that patient. I'm saying, okay, I'm pointing this way. So you know, this way is Krisani Baragwana, not Charlotte. Let's just go through quickly on those questions that were not replied. The common question is restrictions. Let's just take one thing out of the picture. We cannot shut down the economy. We can't ask the National Command Council to shut down the economy completely because one of the things about Gauteng is that it is an economic entity. People are here for economic purposes. So if we shut it down, we must answer the question, how are we going to assist people to offer relief? So we have been managing COVID. We are part of the National Command Council. We can't say to them, no, see to finish. No, the people who are here are people we really, really worry about. Simultaneously, we can't say this situation will solve itself. That's the point I was making in the legislature. We cannot afford to shut down the economy. We can't even ask the National Command Council, please close down Gauteng, because these things are in our hands. Slowing down the pandemic is in our hands. It's engaging with people, as we have done particularly during the second wave. Engaging with people, it's in our hand. Because the hurt that goes with just shutting down the economy, and the clinicians would say, at the rate where we are, will that have an impact immediately? And the epidemiologists would also say it takes a while to factor. Just level 3 that was introduced last week, that it takes a while to really start to show itself. So I think the criticism is something that we really live with. If you, and I have a great deal of respect of those who speak, who advise, who say, I think someone who says Gauteng was not ready for the third wave needs to say this. What is it they didn't do? It's very simple to simply say we were not ready for the third wave because we are still the same entity. We dealt with the first wave. We dealt with the second wave. 4 weeks ago, it's possibly even more than 4 weeks, on the 17th of May, you might remember, on the 17th of May, I'd said, based on clear indications from the clinical team, and they themselves felt like, oh, Premier, isn't it too early? I'd said Gauteng has entered the third wave. That's 4 weeks ago. But the National Command Council makes decisions on looking at the totality of the pandemic. And I think that is correct. They look at the totality of the pandemic. You might not remember that the Northern Cape has been in the second wave since probably January. It hasn't. There's a common agreement that the Northern Cape has been in the second wave. When we get to they are now going down. They are not going down from the third wave. They are now going down. They've been in the second wave for as long as that. The National Command Council also cautions quite a lot, including the advisors, the MAC, about what can you implement. Can you implement different levels in different regions, provinces? I think a province like Gauteng, you have to understand, it's very central to is the organic link with not just the inland provinces, the coastal provinces as well. So those kind of considerations, national takes them into account to say if for example, at this stage, you can't protect, because the infection is here. Community infections are in Gauteng. At this stage, the problem is not coming from outside. So the infections are already here. The only way to take the infections down is engage with the people and introduce the kind of restrictions that are localized, if you like. So at this stage, there was a period where Gauteng infections were very low, but the Free State, the Northwest, and the Northern Cape were red as of the level of risk. And if you understand South Africa, is that the provinces that are always integrally linked. When the pandemic reaches a certain level in that province, then most immediate neighboring province is going to be affected. I'm saying the National Command Council takes those kind of issues into account. So Mangoba criticism will always be there. I want to say that from where we are, if you say, have you created additional beds? At the first point of the first wave and the second wave, there are beds we have added now that were not ready that time. The only difference is that there are others. So we lost 1,000 beds. That's Charlotte. We didn't plan to lose 1,000 beds. That is a real setback. Taking out Charlotte out of the play. Why delay introducing harsher restrictions? We don't introduce harsher restrictions. It's the National Command Council that introduces harsher restrictions. But one thing I want to emphasize is that closing down the economy is really unthinkable. It is inconceivable to introduce level 5. What are you going to do with these people, all of them? You remember during that level 5 restrictions, there was lots of resources pumped into helping businesses, helping people who were, it is unsustainable. So we will have to look at other measures. But are there more restrictions that may include level 4? I would like you to give us an opportunity to be engaging with our National Command Council. It's not for the first time where questions are asked about a certain detail. I say there are discussions that, and where is Malungelo? He said, what did you say to the president on restrictions? He knows he won't get an answer. But I did talk to the president, for sure, on the situation. This week, I did talk to the president. But if you say, what did you say to him? No, I don't talk to the president that way. And I think the president has expressed his deep concern publicly about the situation here. I've been talking to the acting minister of health every day on these issues. So all one can say is that the balance between saving lives, and then protecting livelihoods, that balance cannot be abandoned. It will be completely irresponsible to do otherwise, and kind of somewhat populist. If as a provincial leader, I just think that national government, please close down Gauteng, it will be populism to the extreme. I must be able to answer the question. So what do you do with those people in Gauteng who were shutting down? Our economy is only slowly recovering. We can't afford to stop the recovery, but we can afford and we can avoid to slow down the pandemic and contain it. So we can't afford to shut down the economy to stop the recovery. We can avoid to strengthen restrictions and slow down the pandemic at the rate it is going. And some of that can be just by people helping us to adhere. And I spoke a lot today about localized. The National Command Council has said that again and again. The idea of just moving one province to a different level versus another province, it's a very complex issue, especially with a province like Gauteng, which is integrally linked to the rest of the economy. I wouldn't advocate. I think I wouldn't advocate for a situation where it is thought you can. If you are shutting down the Gauteng economy, you are shutting down the South African economy, and you have to answer very, very difficult questions. I've said earlier on that we have to live with COVID and manage this. Nasrec, at the height of level 1 and level 2, Malungelo, Nasrec had very few people. The only thing, MEC, I want to add, yes, there were oxygen points there, not ICU, but oxygen points. There were oxygen points, I think about 350 oxygen points, but most of those beds were, and when we were going to the second wave, we had taken a decision that we must ramp it up. And look what happened. The second wave just came down quickly. That's why I'm saying, Malungelo, to be in leadership, you will be criticized. And Makingwan. At that time, we were being criticized that, including by clinicians, look, they have built a white elephant, Nasrec is empty. There are no people. So if you want to run away from being criticized, the issue is criticism fair? Did you do your best? We were criticized heavily, even by political parties. Nasrec is there, is a white elephant, is empty. As if we create patients. You know, we must make sure it's full. When people are less affected, they are complying. It will be empty. Those are the risks. The Western Cape at some point had to close that. You remember the Cape place of hope? They had to close it completely. And when the second wave came, they took that decision as the second wave, in the middle of the second wave, to reactivate it. So that's why when I get a message from Premier Windy, we have been there, Premier. We have gone through what you are going, we understand. Fight on. We work like that. With the premiers, we work like that. No pretense that they didn't go through a sharp moment where they were overwhelmed. No pretense. Being criticized, we had to close Nasrec. It was said it was wasteful expenditure. And this thing was coming from the people in the legislature. And we had to close it down, and the evidence of the numbers at that time said. But your question also is, are you looking at that? Yes, we took that decision already, that activating Nasrec is one of those things. It's just that I didn't want to be that detailed. We took that decision in our cabinet. It's not, so closing down and opening, it's not only here. Look at New York, look at Spain, look at Italy. Closing down when the first waves came, and then ramping up again is not something unique. So that's why I'm not worried about it. So when you say they were not ready, and someone says they should have kept Nasrec, and then we're told you are spending a lot of money there and the place is empty. So either way, you will be criticized. But what must be your concern? Let's respond to the critical issues of the time. And some criticism will be fair, that no, what about that? And other criticism is just in the, and criticism builds. It's in a democratic society, leaders must be criticized, especially people who occupy public office. They mustn't expect people to clap hands for them. There will be criticism about opening of Charlotte Maxeke. I expect that there'll be other people who will criticize. We are not here for people to clap hands for us. We just need to focus on getting things that need to be done. And this is where it is extremely important that sometimes in government you can get drawn. Decisions can take decisions. This is what when we talk about the ethical, developmental, capable state, there's a lot of red tape in our system of government, where decisions that need to be made take long. So you need legal advice. Part of the reason, this decision could have been made 2 weeks ago, but you need legal advice, Premier. The lawyers, the state law advisors need to say whether you can make this decision. And sometimes, so Carol says, you know, the Department of Infrastructure Development took 5 weeks to appoint contractors. What Carol doesn't know is that with the current regime of the PFMA and how people abused, not so long, how people abused an emergency situation and did not follow procedures. And the AG came and was correctly so damning on, even if there was an emergency, you should have taken your time, go out, put out this. So I am the last, the team knows that I am, the team even from infrastructure development, I'm very critical, our cabinet knows, I'm very critical around the pace at which infrastructure delivery is taking place. But on appointing contractors, I can't force them to have to make decisions without saying, following they say, we are going to go out, it will take us this time to put this out publicly, and then have what they call these teams, Thabo, that make decisions on a bid committee. And when the officials come to you, we just come out of a situation where there was a lot of abuse. People abuse the emergency situation to make decisions with evil intent, with intention to. So when a department says we can only make this decision by first doing this, I can't push them, and later the AG comes back. All I normally do is, why are you so heartless? Why should it take us so long? If it was an NGO gift of the givers, they would do this thing within 1 day. And so their government, red tape can be something that can be quite frustrating. And also there are also red tape, but there's also inefficiencies, and sometimes hidden there is overpricing. And those things we always have to treat. It has taken long. I know Thabo and I were part of many meetings. We know where there were delays that were a result of how long it took DID. But there were also delays that were a function of the city says you must first do this. And to do this, you need to get this material, you need to go out and source this material. That's why the DID is now working with the Solidarity Fund to source out material of this type and that type. So all I can say, Carol, is that it was not acceptable for me for this hospital to be closed from the beginning. After 7 days, we wanted the hospital to resume. But at that time, there was no engineering report. that said which part of the hospital is damaged. After that, then there was the city that rightfully has its role to play to say, no, you have to do this first, you have to do that, you have to comply with this. So I cannot accept that decisions cannot be made quickly in a government and that things must take long. Or decisions must not be made. Charlotte must remain closed. I can't accept that system of government. I can't be there and think that I'm doing a work that serves the purpose of people. All I'm doing there is to say I'm complying, my hands are tied. We can't open the hospital even if people need the services of the hospital. So I think in that way, I often have a lot of frustration, but decision time is decision time. I can't complain as a leader. We have to reach this point. We have made these decisions. We have to fix the other parts of the hospital. And DID knows they are always on our radar screen. If they don't move on things, we are taking action against that kind of lapse. Any oxygen shortage? Not at the moment. Not in our facilities. But remember, we have a huge system. If you think of the public and the private sector, the MEC was saying that she receives reports from facilities daily. Is block 1 and 2 opening immediately? Yes. Immediately, as of, we took the decision yesterday, and the hospital management presented, I think this is Griselda Lewis from SABC. Yes, block 1 and 2 are opening with immediate effect. With immediate effect, it is the hospital management that's having the plan to bring in back those services. But that, they know, we said to them with immediate effect, but they have to organize that space in a way that will provide the kind of service. All we know is that there will be space for COVID interventions in there, neonatals, which they said is where the pressure is, and they added several other services that will be brought in. All these things are phased in. After that, block 1 and 2, it will be the other blocks, we're hoping 3 and 5, but block 4 will be last. And I know, is it Carol who said, when is the entire hospital opening? The structural damage on block 4 is severe, Carol. And we, in the schedule of, in the plan of the department, that will be the last. They are reporting regularly. There's still some structural assessment that's being made on that block. I am not able to say at the moment. The last block is going to be block 4, which is the one where the major damage is. I'm not able to say at the moment when will that part come through, because I also don't want to announce something and come and change later. I want to be sure that when they present about the last phase, at the moment we said to them, focus on the emergency. Those areas that are not structurally affected by the fire, focus on bringing those back and work backward on that. We dealt with any patients from Gauteng. And I know, Carol, I think you have been very critical, and that criticism is something that we value. You have been very critical about the closure of Charlotte. It strikes the right chord. It is something that has been quite heavy. I have gone there, had many meetings with the MEC and the hospital team there, and gone back to meet with the other teams that include the city. everybody knows, I've never accepted that we should allow all the people we have worked with. I've never accepted that we should sit back and say there's nothing that can be done. I've always said we must do something to reopen the hospital urgently. Of course, let's look at the issues of safety. Let's look at the role of the hospital in saving lives. That's extremely important. I think there was Charlotte still talking about restrictions. I said specific, if colleagues are waiting for what level will really help Gauteng to stem the tide, that decision can only be made at a national level. I think we are clear. We will do everything at the level where we are. Stembele again, what restrictions? Anything that has to do with provincial authority, has already been explored. It's about what we can do with law enforcement. It's about what we can do with regulation that's within our authority. And I've already explained that we have been engaging with the liquor traders and engaging with the liquor traders until there is a real indication that this is where the super spreader, this is the super spreader events. Engaging with them, it's something we do so that if we have to come to a decision, it shouldn't be an easy decision to make, but we must also be guided by evidence. If the clinicians are saying to us quite clearly, part of our problem now is that people are, I would like to hear that kind of issue. We have been working on the regulation of, just outside COVID-19, regulation, issues of regulation of the sale of alcohol. We are revising the regulations in our province beyond COVID. There are a lot of concerns around tightening regulation around alcohol. So I think that really deals with the key issues that were raised. The other issues, Tabot, are the ones we can answer separately. But I want to say that as the province, we will continue to do what we have to do. When we are criticized, we accept that criticism in kind. But that criticism will always be there. And we were criticized before, but we're also drawing lessons, Malungelo. We're drawing lessons on how emergency regulations must not be used to bypass, especially procurement systems, because corruption is a very big problem in this country. Don't want anyone to come and say, we ended up giving this tender because we were pressurized. It was because of COVID. The Minister of Finance did say that those emergency procurement do not replace following proper procedures. And I can tell you, there are officials, they're out there who are always looking for an opportunity to be told by the Premier, please go and do this thing urgently, and use that urgently as a reason to go and do something else, especially when it comes to procurement. I can't see us landing in that same situation. People must follow the procedure, especially on procurement. It must be done according to law, but we want swift and clean decisions. If they don't do that, and then they will be caught. If anyone wants to use the current situation to get involved in corrupt acts, they will be caught. At least what is clear in our conscience is that with the reopening of Charlotte, we are only concerned the principal concern is about lives of people. There's no other concern that hospital must operate and save people. Every other thing will still follow a procurement process. That's why when the team from DID said to us, no, we can only open in September because we must follow all these wards that are not structurally damaged. We came to that conclusion after consulting with a whole range of people. We came to that conclusion that that is not something that can be justified with our conscience. If we are asked the question, did you do enough? Did you push hard, Premier, that this hospital that is so key needs to be made available? I will say, yes, we did push hard to get it reopened and be made available. And this is something we can live with our conscience. That we didn't just throw the legal opinion at the clinicians and then throw the rules of the city at the hospital and say, no, we can't do anything. The rules of the city are saying this, and the legal advice is saying this. That's not leadership. It's not worthy of being here. When you are faced with what we are faced with, it's not worthy of being here to simply say, hey, there's nothing we can do. So that is why we must do everything, MEC. We must do everything to push the surge back. And that includes the people of our province doing something. And if people continue on the ground, as you say, Mangoba, on the ground, the situation is not looking good. Help us to get this message. Just please know that we can do only this much. If there are more people going out and marching and attending all this, I guess you can have as many hospitals, you are still going to be overrun. If there's no slowing down there, you will be in big trouble. So we just want to handhold with the people to work together. Thank you so much.
Okay, thank you very much, Premier and MEC. We have come to the end of this briefing. We will meet again when it's time for another briefing. Thank you.
Kalle Udin Sihai Samaya